بسم الله نبدأ دكتور محمد على بركة الله. بسم الله.
Okay, thank you, Musab. Greetings to all our audience from different parts of the world on our second day of first International Saudi German Hospital Madinah Stroke Symposium. First day, it was a fruitful day, and we were taken into a journey regarding transient ischemic attack and small vessel disease. And today we are going through another hot topics in stroke medicine. Today we are honored to host outstanding speakers from Germany, Egypt, and Saudi Arabia. Today we have Professor Dr. Helmut, Head of Neurology Department, Goethe University, Frankfurt, Germany, and Professor Dr. Azza Abdel Nasser, Professor of Neurology and Stroke Medicine, Faculty of Medicine, Ain Shams University, and Dr. Ahmed Kouhil, Coordinator of Stroke Program, Saudi German Hospital Medina, and Fellow of European Board of Neurology. Today we have two different topics. One topic regarding prevention strategies in transient ischemic attack and stroke, presented by Professor Dr. Azza. And we have personalized counseling for patients with an ruptured intracranial aneurysm, presented by Professor Dr. Helmut. And we will have interesting various case scenarios about stroke patients, presented by Dr. Ahmed Kouhil. We will start our day with Professor Dr. Azza Abdel Nasser, who will present to us a lecture about the preventive strategies for transient ischemic attack and stroke. If anyone wants to ask a question, he can hit a question in question and answer bar. And at the end of the three sessions, we will discuss with our speakers regarding the answer of the questions. Now, Dr. Azza, you can start, and we will share the presentation now.
Thank you, Dr. Mohammed, for your kind introduction. Really, I have the honor to share with you today that great scientific activity under the supervision of academic affairs of Saudi German Hospital in Madinah Munawwara. Really, I thank you for your kind invitation, and also I'm deeply honored to join this session with Professor Helmut and Professor Ahmed Kouhil. Today, my lecture will tackle the prevention guidelines of ischemic stroke. Next. Regarding stroke prevention, stroke continues to be a common and debilitating disease, posing a major public health problem. There have been encouraging positive trends regarding risk factor control and stroke prevention. With aging population, the global burden of stroke is likely to be substantially increasing, and therefore to implement the effective primary stroke prevention strategies is more important than ever. The new guidelines for primary prevention offer up-to-date, comprehensive, evidence-based recommendations, including number one, well-recognized risk factors such as hypertension, diabetes, diet, lifestyle, and the less well-recognized stroke risk factors like migraine, metabolic syndrome, obstructive sleep apnea, and asymptomatic carotid stenosis. Regarding the stroke burden in the Middle East, the incidence of stroke in the Middle East is about 100 to 200 per 100,000. The stroke incidence declined by 40% in the past 4 decades, and this is because of the very advanced techniques of investigations and the very strict application of the different treatment protocols according to the guidelines. Next. Next. Stroke is a major public health problem. Worldwide, nearly 6 million patients our people die every year from a stroke. And also, 1 in 6 people on average will suffer a stroke in their lifetime. Next. The risk of stroke regarding either unchangeable risk factors such as age, gender, family history, and race, and the other modifiable risk factors such as blood pressure, increased blood pressure, hypertension, diabetes, atrial fibrillation, smoking, obesity, heart disease, stress, high cholesterol, and lack of exercise. Stroke is a huge burden on the society, but it is preventable and treatable disease. Control of risk factors is very important for prevention. Life Simple 7. Life Simple 7 is an easy formula, which was discussed yesterday by Professor Hani Arif. And also, cardiac health is a very important issue for the brain health. Regarding the updates in the guidelines of prevention of stroke in stroke patients with ischemic stroke and TIA or transient ischemic stroke, published the updates 2021 in Journal of Stroke, as recommended by the American Heart Association and American Stroke Association. Next. Regarding the conceptual representation of ischemic stroke subtypes, we know that ischemic stroke represents 88% for the total strokes, and on the other side, the hemorrhagic stroke represents 12%. Regarding the ischemic stroke, 77% are non-lacunar and 23% are lacunar. From the graph also, the non-lacunar strokes composed of 35% cardioembolic, 45% cryptogenic, and large vessel representing 17% and others representing 3%. Cryptogenic stroke either eases embolic stroke of unknown source or non-eases the other presentation of other subtype of the cryptogenic stroke. Next, the figures, the MRI figures. I will show you now the MRI figures. In the MRI figures, when the first one to the left, we see here is the large artery stroke, stroke caused by large artery atherosclerosis. On the MRE, we found there is occlusion of the internal carotid artery on the left side as well as the left MCA. Ischemic stroke in the distribution of that major intracranial vessel with a significant stenosis appear on vascular imaging. In the middle, this is the lacunar stroke. Here in the periventricular, there's a lacune shown in the middle MRI. The lacunar syndrome is a subcortical infarction measuring less than 1.5 centimeter here appearing on MRI. The third one on the right, it shows multiple infarctions, cortical and subcortical, which most probably can make be the picture of vasculitis. Regarding other type, which is this one, is large cortical infarction. Most probably, it's one of cardioembolic stroke, which is attributed to the arterial occlusion from an embolus that enters the heart, and it appears similar to that as if it is a large artery atherosclerosis, but evidence of a previous TIA or stroke in more than one vascular territory supports the clinical diagnosis of cardioembolic stroke. Then we shift now to how we can make diagnostic evaluation for secondary prevention. We must, in the patient suspecting of having a stroke or TIA, ECG is recommended to screen for the atrial fibrillation and atrial flutter. In patients with ischemic stroke, diagnostic evaluation is recommended in order to gain insights in the etiology and planning optimal strategy for the prevention. Also, in patients with symptomatic anterior circulation, cerebral infarction or TIA are candidate for revascularization, so we must make for them or assess them by cervical carotid imaging with carotid ultrasound or CTA, CT angiography or MR angiography. It is recommended to screen the underlying stenosis. In patients with confirmed diagnosis of symptomatic ischemic cerebrovascular disease, blood tests must be done, including CBC, PT, PTT, glucose, HbA1c, which is glycosylated hemoglobin, glycated hemoglobin, creatinine, and fasting lipid profile are recommended to gain insight into the risk factors, and hence you can know what you are going, and you can detect what are the therapeutic goals. in cryptogenic stroke, echocardiography, long-term rhythm monitoring to detect atrial fibrillation, as we mean Holter, test for the inherited acquired hypercoagulable state, vasculitis, drug-induced must be considered, and we must search after all of these underlying causes or factors. In patients suspected of having ischemic stroke, MRI doesn't demonstrate the symptomatic cerebral infarct. Follow-up MRI must be done in order to confirm the diagnosis. In patients with ESUS, transesophageal echo must be done. Cardiac CT or cardiac MRI might be reasonable to identify the possible cardio-aortic sources of or transcardiac pathways for the cerebral embolism. In patients with ischemic stroke or TIA, whom PFO, patent foramen ovale, closure would be contemplated. TCD, transcranial Doppler, with impulse detection through the technique what's called HITS, high intensity signals, be reasonable to screen for the right to left shunt. What are the important factors we are searching and we are evaluating in order to reach the proper prevention for the patient suffering from stroke or TIA? Vascular risk factors are very important factors. We must search and must assess and must treat and adjust. Number one, lifestyle, including nutrition, physical activity, and smoking. Regarding nutrition, in patients with a stroke, we must ask the patient to follow what's called the Mediterranean type of diet in order to improve the type of diet in order to reduce the risk of recurrent stroke. And also, if the patient is stroke or TIA with hypertension, we must ask the patient recommending to reduce their sodium intake at least 1 gram per day sodium in order to reduce the risk of cardiovascular disease and events. As shown in this table, the next table, we have two types of diet. The Mediterranean diet, which is composed of high monosaturated when weighted to the saturated fat, composed of high intake of plant-based food, high consumption of whole grain, increased consumption of fish, low consumption of meat and meat products, discourages red and processed meats, and moderate consumption of milk and its products. On the other side of the table, it's called the DASH diet. DASH diet means that indicates the dietary approaches to stop hypertension. So patients with stroke and hypertension have limited saturated fat, emphasize to increase the consumption of fruit, vegetable, and legumes, increase consumption of whole grain, also limits the red and processed meats, and increase the fat-free or the low-fat diet. So it is very important to recommend this type of diets for the patients suffering from stroke or TIA in order to reduce the cerebrovascular events. As regards the physical activity, in patients with stroke or TIA who are capable for physical activity, we recommend at least moderate intensity aerobic activity for a minimum 10 minutes 4 times per week, or vigorous intensity aerobic for 20 minutes twice a week. This is very good. Activity must be done in very regular way in order to decrease or help in decreasing the recurrent strokes and the risk of the cardiovascular complications. But what about the patients who have deficits after stroke, impaired their ability to make exercise? So they must have a supervision of an exercise program by a healthcare professional, such as a physical therapist or a cardiac rehabilitation profession, in order to help them in their activities. In addition to the routine rehabilitation, can be beneficial for the secondary stroke prevention. Regarding smoking, smoking is one of the important risk factors. So stoppage of smoking or cessation of smoking is very important. We must ask patients who develop a stroke or TIA who smoke tobacco by counseling with or without drug therapy, such as nicotine replacement or bupropion, is recommended to assist the quitting the smoking. Also, a patient who can advise them to stop smoking and they couldn't stop it. We can ask them to reduce their daily smoking. Also, the passive tobacco smoking must be avoided because it's have a role in reduction of the risk of recurrent stroke. Regarding hypertension, in patients with hypertension who experience a stroke or TIA, treatment with the angiotensin converting enzyme ACE inhibitor, or angiotensin II receptor blockers, ARB, is useful for the lowering of the blood pressure and reducing the recurrent stroke, and they have a role in neuroprotection. In patients with hypertension who experience a stroke, the goal of our blood pressure for them must be around 130/80 millimeter mercury for most of the patient in order to reduce the risk of recurrence. Regarding hyperlipidemia, in patients with ischemic stroke who have no history of coronary heart disease or major cardiac sources of embolization, the target of LDL for them must be around 100 milligram per deciliter. This, in addition to atorvastatin, 80 milligrams daily, is indicated to reduce the risk of the stroke recurrence. If the patient has ischemic stroke or TIA and he has atherosclerotic disease such as intracranial or carotid or aortic or coronary, lipid lowering therapy with a statin, and also need to make our goal of LDL cholesterol low, must be around 70 milligram per deciliter. It is recommended at that level in order to reduce the risk of recurrence. It's important to monitor the patients who are on statins in order to know whether the patient is adherent, whether the patient is this type of treatment is effective for him or not. So the monitoring must be 4 to 12 weeks after the dose adjustment or starting of the statin, and then after that we follow up every 3 to 12 months in order to make sure that the patient is adherent to his treatment and then to make sure of his safety. Regarding glucose, in patients with ischemic stroke or TIA who have diabetes, the goal for the glycemic control should be individualized. Every patient tailored according to his adverse events, according to the patient characteristics and preferences. And for most of patients, those below 65 years of age and without life-limiting comorbid illness, achieving a goal of HbA1c less than 7 is recommended to reduce the risk of the microvascular complication. In the patient with an ischemic stroke who have diabetes, treatment of diabetes should include glucose-lowering agents with proven cardiovascular benefit to reduce the risk of the future major adverse cardiovascular events, such as stroke or acute MI. Also, in patients, on the other hand, the patients who are pre-diabetics and develop stroke or TIA, lifestyle optimization, such as a healthy diet, regular physical activity, and smoking cessation will be beneficial for the prevention of the progression into diabetes. In patients with pre-diabetes, particularly if the patient BMI is more than 35 kilograms per square meter, patient is less than 60 years of age, patient is a woman with a history of gestational diabetes, metformin may be beneficial to control the blood sugar and to prevent the progression into to be really diabetic, not pre-diabetic, she will pass into diabetes. As regard obesity, one of the important factors in patients with ischemic stroke and TIA who are overweight or obese, they must make weight loss. Is recommended to improve the atherosclerotic cardiovascular disease risk factor profile, and also in patients with ischemic stroke or the atherosclerotic cardiovascular disease, calculation of a BMI is recommended at the time of their event. And then annually, you must follow up the BMI for those patients in order to screen for and to classify obesity. Obstructive sleep apnea, consider one of the factors we must search and we must treat and we must assess in order to decrease the risk of development or stroke or the risk of recurrence of stroke. In patients with ischemic stroke or TIA who have obstructive sleep apnea, treatment with the continuous positive airway pressures, CPAP, can be beneficial for the improved sleep apnea improvement of the blood pressure, improvement of the sleepiness, and other apnea-related outcomes. The next one, we will shift now. One of the methods of prevention is to do good classification and know what is the type of the affection, what is how to manage according to the etiology, what is the underlying etiology. If the patient have large artery atherosclerosis, for example, intracranial large artery atherosclerosis, what is the recommendation? The recommendation by antithrombotic therapy for those type of patient have large artery atherosclerosis who develop stroke or TIA and have 50 to 99 stenosis of a major intracranial vessel. Aspirin is recommended, and in preference to warfarin. We prefer aspirin more than warfarin to reduce the risk of recurrent ischemic stroke and vascular complication. In patients with recent stroke or TIA within 30 days, with severe stenosis, 70 to 90% of a major intracranial artery, the addition of clopidogrel 75 milligram per day, in addition to the aspirin, up to 90 days is reasonable, and it have a great good effect in reduction of the recurrent stroke in the further days. So in patients who have recent stroke within 30 days and what that type of stenosis, severe stenosis, 70 to 90%, dual antiplatelets can be considered as the best management for them, especially in the first 90 days in order to reduce the risk of recurrence. Also in patients with stroke or TIA, when the stenosis 50 is moderate, 50 to when the stenosis 50 to 99% stenosis of a major intracranial artery, maintenance of the systolic blood pressure below 140 millimeter mercury is very, very important. Also, high intensity statin therapy is very important, and at least moderate physical activity are recommended. So we must, for those patients, in addition to the double antiplatelet or dual antiplatelets, we must maintain systolic blood pressure below 140 millimeter mercury. We must maintain high intensity statin therapy, and we must at least moderate physical activity. In patients with severe stenosis, 70 to 90% of a major intracranial artery and actively progressing symptoms or recurrent TIA or stroke, after institution of aspirin and clopidogrel and achieving of the systolic blood pressure less than 140 millimeter mercury and the high intensity statin therapy, so-called medical failure, as if we have medical failure. So the usefulness of the angioplasty alone or stent placement to prevent the ischemic stroke in the territory of the stenotic artery is still debatable. On the other hand, regarding the extracranial large artery atherosclerosis, the second type of large artery affection, in patients with carotid artery stenosis and TIA, intensive medical therapy with antiplatelet therapy, lipid lowering therapy, and treatment of hypertension is recommended to reduce the stroke risk. In patients with on those patients with ischemic stroke and ipsilateral moderate 50 to 69% carotid stenosis, as documented by catheter angiography or a non-invasive imaging, carotid endarterectomy is recommended to reduce the risk of the future stroke depending on patient-specific factors such as age and comorbidities. In patients more than 70 years old of age with stroke and TIA in whom carotid revascularization is being considered, it is reasonable to select carotid endarterectomy over the carotid artery stenting to reduce the stroke rate during the procedure. Next, the third cause, ischemic stroke caused by small vessel disease. In patients with ischemic stroke related to small vessel disease, the usefulness of xylostazole for secondary stroke prevention is still debatable. Some studies recommended the xylostazole as an important antiplatelet drug can be used for small vessel disease, but still this issue is debatable. Another important issue help us in prevention stroke to help patients in order to avoid repeated strokes or repeated TIAs is the cardioembolism. Cardioembolism, the main important cause underlying this cardioembolism is the atrial fibrillation. Atrial fibrillation is an important cause of the cardioembolic stroke, and the initial clinical presentation of AF can be a stroke or TIA. It will be the first presentation for that patient. The first time for him to detect that he has AF when he presents for the first time with stroke or TIA. In patients with ischemic stroke or TIA, a diagnosis of atrial fibrillation allows the reduction of the recurrent events by treatment with the long-term oral anticoagulation. In a series of patients with stroke and AF evaluated by echo, 90% of identified thrombus was seen in the left atrial appendage. 4 approved direct-acting oral anticoagulants, DOACs, have been studied in large randomized trials and shown to clinically reduce the risk of the thrombotic stroke with less bleeding risk compared to vitamin K antagonists. In patients with non-valvular AF and stroke or TIA, oral anticoagulation by the DOACs, acting oral anticoagulants, apixaban, dabigatran, edoxaban, and rivaroxaban or warfarin is recommended to reduce the risk of the recurrent stroke. In patients with AF and stroke, anticoagulation is indicated to reduce the risk of recurrent stroke regardless of whether the AF pattern, paroxysmal or persistent or permanent. So the aim of our recommendation for anticoagulation to prevent the recurrence or the risk of recurrence of stroke. This is the main issue for the use of the anticoagulation. So it is not related, whatever the pattern of AF, what is this, is paroxysmal or persistent or permanent, it's not the issue. Regarding the valvular diseases, in patients with ischemic stroke or TIA, valvular AF, moderate to severe mitral stenosis, or any mechanical heart valve, warfarin is recommended to reduce the risk of recurrence. Also, the patient with mechanical mitral valve and history of ischemic stroke or TIA before valve replacement, aspirin can be recommended in addition to warfarin with an INR can target up to 3 to reduce the risk. This is the importance of anticoagulation in valvular lesions with mitral stenosis. Regarding the left ventricular thrombus, in left ventricular thrombus in patients with stroke or TIA, left ventricular thrombus, left ventricular thrombus, anticoagulation with therapeutic warfarin for at least 3 months is recommended to reduce the risk of recurrence. Also, in patients with stroke or TIA and new left ventricular thrombus less than 3 months, the safety of anticoagulation with direct oral anticoagulant, DOACs, reduce the risk of recurrent stroke is still debatable. In patients with stroke or TIA in the setting of acute anterior MI with reduced ejection fraction less than 50%, but no evidence of left ventricular thrombus, empirical anticoagulation for at least 3 months might be considered to reduce the recurrence of stroke. Regarding cardiomyopathy, in patients with ischemic stroke or TIA and left atrial or left atrial appendage thrombus in setting of ischemic, non-ischemic, or restrictive cardiomyopathy and left ventricular dysfunction, anticoagulation therapy with warfarin is highly recommended for at least 3 months to reduce the risk of recurrence. In patients with ischemic stroke or TIA, sinus rhythm with ischemic, non-ischemic cardiomyopathy and reduced ejection fraction without evidence of left atrial or left ventricular thrombus, the effect, the anticoagulation is better in comparison to antiplatelets. Patent foramen ovale in patients with a non-lacunar ischemic stroke of undetermined cause The patent foramen oval recommendation for patent foramen oval occlusion versus medical management should be made jointly by the patient and by the cardiologist and by the neurologist, taking into account the probability of the causal role of the PFO. In patients from 18 to 60 years of age with an imaginary ischemic stroke of undetermined cause despite the evaluation, PFO with high-risk anatomic features, it is reasonable to choose closure with transcatheter device, and long-term antiplatelet therapy is recommended alone is the platelet therapy over antiplatelet alone. Yani we must do the two types of treatment. The transcatheter device to close the PFO and also the antiplatelet therapy. This is a diagram showing the different choices of drugs in every situation, as we mentioned before. Next. Next. We will shift now to the next with dissection. Extracranial, carotid, or vertebral dissections can be the result of trauma or spontaneous occurs spontaneously. It is a relative uncommon mechanism of ischemic stroke that is relevant mostly to younger individuals. The most common mechanism of stroke with extracranial dissection is artery to artery embolism from an intraluminal thrombus, which is the rationale for the using antithrombotic agent to decrease the rate of ischemic stroke. So in patients with ischemic stroke or TIA after an extracranial, carotid, or vertebral arterial dissection, treatment with antithrombotic therapy for at least 3 months is indicated to prevent recurrence of stroke. In patients with ischemic stroke or TIA who are less than 3 months after an extracranial, carotid, or vertebral dissection, it is reasonable to use either aspirin or warfarin to prevent the recurrence of stroke. The next is the hypercoagulable states. Hypercoagulable state referred to heterogeneous hematologic traits that predispose to the venous or arterial thrombosis, which may increase the risk of stroke. In patients with ischemic stroke or TIA unknown source, despite diagnostic evaluation and no other thrombotic history, who are found to have prothrombin mutation, activate protein C resistance, elevated factor 8 levels, or deficiencies of protein S and C, or antithrombin 3 or antiplatelet therapy is reasonable to reduce the risk of recurrence. One of the most important hypercoagulable states is the antiphospholipid syndrome. Antiphospholipid syndrome is caused by the persistent repeated testing 12 weeks apart, presence of the lupus anticoagulant, anticardiolipin, plus evidence of clinical criteria such as vascular thrombosis or pregnancy morbidity. Serum testing for acquired antiphospholipid syndrome may be considered in the presence of a history of prior venous thromboembolism. That patient, when you ask about his history, I mean, we found that has a prior history of venous thromboembolism, a second trimester abortion for a pregnant female, or rheumatologic disorder. Patient with stroke and persistent seropositivity for any of the antiphospholipid antibodies may be classified as having antiphospholipid syndrome. How to manage this in this condition? In patients with ischemic stroke, TIA, who have an isolated antiphospholipid antibody, but not fulfilled all the criteria for the antiphospholipid syndrome, antiplatelet therapy alone is recommended to reduce the risk of the recurrent stroke. In patients with ischemic stroke with confirmed antiphospholipid syndrome treated with warfarin, and it is reasonable to keep our target for the INR around 3 to be effective. In patients with ischemic stroke or TIA who meet the criteria for the antiphospholipid syndrome, it is reasonable to anticoagulate with warfarin in order to reduce the risk of recurrence. Regarding hyperhomocysteinemia, although the elevated serum levels of homocysteine has consistently been associated with elevated risk of stroke and other vascular events, randomized trials of folate and B vitamin supplementation have not shown benefit in secondary prevention of stroke. So in patients with ischemic stroke or TIA who have hyperhomocysteinemia, supplementation with folate, B6 and B12 is still debatable and maybe not effective. Sickle cell disease is autosomal recessive inherited hemoglobinopathy affect people predominantly in the African and Mediterranean areas. The normal, flexible, round blood cells is transformed into sickle appearance. These sickle cells have abnormal interaction with the vascular wall, endothelium, so other blood cells and clotting factors. So this results in thrombosis or hypoperfusion and ischemia globally, and ischemia. As we said before, most of the patients are younger in age, and most of them in the African or Mediterranean areas. In patients with sickle cell disease, prior ischemic stroke or TIA, they must have chronic blood transfusions to reduce the hemoglobin S to less than 30% of the hemoglobin in order to prevent the recurrence or the occurrence of ischemic stroke. In patients with sickle cell disease with prior ischemic stroke or TIA, home transfusion therapy is not available, or practical treatment with hydroxyurea is reasonable for the prevention of recurrence. Either we use the blood transfusion in order to reduce the hemoglobin S to less than 30% of the total hemoglobin, or if the patient is not given good results with the blood transfusion, or the patient is not practical for him to make this chronic blood transfusion, we can use the hydroxyurea in order to prevent the recurrence of ischemic strokes for further. As regards vasculitis, autoimmune vasculitis is a subset of disease that may cause a stroke. The overall prevalence of autoimmune vasculitis in stroke population is very low, but age dependent. In cohorts of younger age less than 45 years, vasculitis may account from 0 to 20% of stroke cases. In patients with ischemic stroke or TIA, symptoms attributed to giant cell arteritis, immediate initiation of oral high-dose glucocorticoids is recommended to reduce the recurrent stroke. In patients with ischemic stroke diagnosed as giant cell arteritis, methotrexate therapy, in addition to the steroids, is reasonable in treatment in order to lower the risk of recurrence. Also, in addition to induction therapy with glucocorticoids or with immunosuppressant for longer maintenance with steroid-sparing immunosuppressant is reasonable also to lower the risk of stroke recurrence. Now, migraine. We must know that migraine, one of the factors or underlying the underlying pathology may play a role in ischemic stroke and white matter hyperintensities. In patients with migraine who have had an ischemic stroke, data on the risk of recurrent stroke are limited. On the basis of these limited data, practitioners may consider implementing preventive treatment to reduce migraine frequency in patients with migraine and prior stroke, ischemic stroke. Neuroimaging studies suggest that there is brain hypoperfusion during the migraine attacks, at least in severe migraine attacks with oral. The use of oral contraceptive with exogenous estrogen among women with migraine, especially when combined with active smoking, has been associated with an increased risk of stroke in numerous studies, although the quality of such studies is low. On the basis of this data, avoiding the oral contraceptive agents with exogenous estrogen in women with migraine, with aura, and prior ischemic stroke may perhaps be appropriate. Then I'll shift now to the embolic stroke of undetermined source, the ESUS. ESUS is an evolving stroke subtype, and we already have seen in the previous figure when we show the subtypes, and we have cryptogenic stroke. It is the subtypes is ESUS and non-ESUS. ESUS is an evolving stroke subtype, commonly defined as the non-lacunar cryptogenic ischemic stroke. Lack of standard definition has complicated studies of ESUS, with one review finding that many studies used variable diagnostic criteria. This complexity in defining the ESUS is one of the reasons proposed for the negative clinical trials for anticoagulation compared with antiplatelet medication. So in patients with ESUS, treatment with direct oral anticoagulants is not recommended to reduce the secondary stroke. In patients with ESUS, treatment with ticagrelor is not recommended to reduce secondary stroke. This is the proposed diagnostic assessment for the ESUS. It must composed of many methods for investigation in order to search what are the sources of this embolization. Brain CT, brain MRI, 12-lead ECG, recorded echocardiography, cardiac monitoring for more than 24 hours with automated rhythm detection Holter in order to detect the underlying atrial fibrillation or atrial flutter. Imaging, very good image, must make very good imaging with high quality MRI or other techniques in order to image the extracranial and intracranial arteries, supplying the area of the brain ischemia by catheter angiography, MRA or CT angiography, or cervical duplex, plus the transcranial duplex ultrasound, in order to search for what is the underlying pathology. Regarding the management of ESUS, there are two possible strategies for stroke prevention in patients with ESUS. The first was to use more sophisticated tools to detect clinically silent AF. Methods of detecting clinically silent AF by the cardiac monitoring have evolved greatly from the original Holter monitoring equipment to the ambulatory devices and implantable recorders available today. The second is to assume they are cardiac in origin and to give the anticoagulants as a therapy for the ESUS. Then we shift now about the use of the antithrombotic medications in secondary stroke prevention. In patients with non-cardiac embolic ischemic stroke, TIA, antiplatelet therapy is indicated in preference to the oral anticoagulant to reduce the risk of recurrence of ischemic stroke and also the cardiovascular events. For patients with non-cardioembolic ischemic stroke or TIA, aspirin can be given aspirin or clopidogrel 75 milligram or combination of aspirin and extended release diparidamole 200 milligram twice daily is indicated for the secondary prevention, but it is not usually used diparidamole. Usually we can use the aspirin and the clopidogrel. For patients with recent minor stroke, NIH scoring less than 3, non-cardioembolic ischemic stroke, or high risk TIA, ABCD to score more than 4, double antiplatelets, aspirin plus clopidogrel, should be initiated early, ideally 12 to 24 hours from the onset of symptoms, and at least within 7 days of onset, and continued for 21 days up to 90 days. We prefer 90 days, followed by the single antiplatelet to reduce the risk of recurrent ischemic stroke. For patients with recent stroke less than 24 hours, minor to moderate stroke, NIH scoring less than 5, or high risk TIA, ABCD to scoring more than 6, or symptomatic intracranial or extracranial more than 30% stenosis of an artery that could account for the event. Double antiplatelets with ticagrelor plus aspirin for 30 days may be considered to reduce the risk in the first 30 days of recurrence of stroke, but may also, on the other hand, increase the risk of bleeding events. For patients already taking aspirin at time of the non-cardioembolic ischemic stroke or TIA, the effectiveness of increasing the dose of aspirin or changing to another antiplatelet medication is not well established. For patients with non-cardioembolic ischemic stroke or TIA, the continuous use of double antiplatelets, dual antiplatelets, aspirin plus clopidogrel more than 90 days, or the use of triple that may increase the risk of hemorrhage. So we must evaluate our decision in the choice of the single antiplatelet according to a condition, or we put the single antiplatelet alone, we use one antiplatelet, or we can use the double antiplatelet or dual antiplatelets, aspirin plus clopidogrel or xylostazole, but we really shift to use 3 antiplatelet therapy because the risk of hemorrhage is very high. Here is this diagram showing in cases of non-cardioembolic ischemic stroke or transient ischemic attack. If the patient have ischemic attack or ischemic stroke, Is it early ischemic stroke? If yes, we shift what's the NIH scoring. The NIH scoring is minor, less than 3. Yes, you must have dual antiplatelet, and this is class 1 for the first 90 days, and then after 90 days we can shift to the single antiplatelet. If the ischemic stroke early, but no, it's not early ischemic stroke. No, it's not early, so we shift to single antiplatelet. And if the NIH is more than 3, yes, it can shift to a single, and the same for the transient ischemic attack. To conclude, management of vascular risk factors remain extremely important in secondary stroke prevention, including but not limited diabetes, smoking cessation, lipids, and especially hypertension. Intensive medical management, often performed by multidisciplinary teams, is usually best with goals of therapy tailored to the individual patient. Lifestyle factors, including the healthy diet and the physical activity, are important for preventing a second stroke. Low salt and Mediterranean diets are recommended for stroke reduction. Changing patient behavior, such as diet, exercise, and medication compliance, requires more than just simple advice or a brochure from their physician. Antithrombotic therapy, including antiplatelet or anticoagulant, is recommended for nearly all patients without contraindications. Dual antiplatelet therapy is recommended only in very specific patients, including those with early arriving minor stroke and highly risk TIA or severe symptomatic intracranial stenosis. Atrial fibrillation remains a very common and high-risk condition for second ischemic stroke. Anticoagulation is usually recommended if the patient has no contraindication. Heart rate monitoring for occult atrial fibrillation is usually recommended if no other cause of stroke is discovered. Extracranial carotid artery disease is an important and treatable cause of stroke. Patients with severe stenosis ipsilateral to a non-disabling stroke or TIA, transient ischemic attack, who are candidates for intervention, should have the stenosis fixed, likely relatively early after their ischemic stroke. The choice between carotid endarterectomy and carotid artery stenting should be driven by the specific patient comorbidities and features of their vascular anatomy. Patients with severe intracranial stenosis in the vascular territory of ischemic stroke or transient ischemic attack should not receive angioplasty and stenting as a first-line therapy for preventing of recurrence. So aggressive medical management of risk factors and short-term dual antiplatelet therapy are preferred. There have been several studies evaluating the secondary stroke prevention of the patent foramen ovale closure since the previous guideline in 2014. It's now considered reasonable to percutaneously close the patent foramen ovale, especially if the patient is young in age between 18 to 60 years. And in addition to the use of antiplatelets, in addition to the closure of the foramen ovale, and this especially if this non-lacunar stroke or no other identified cause underlying and high-risk patient foramen ovale features. This is the last slide, and I hope you was interested in my lecture, and thank you very much for your attention. Thank you very much.
Thank you so much, Professor Dr. Azza, for that comprehensive and fruitful full-dose lecture about the preventive strategies for patients of transient ischemic attack and stroke. Now we are moving to our great eminent professor, Professor Dr. Helmut Steinmetz, who will take us into interesting and unique presentation about personalized risk assessment and counseling for patients with unruptured intracranial aneurysm. Professor Dr. Helmut, you can start.
Thank you, Dr. Muhammad, for once again inviting me to this symposium, online symposium. Thanks for organizing it, and I'm amazed to see the number of attendants. So that's really proof of success of your symposium.
You are always welcome, Professor.
Now, today I just looked it up and I saw that's the 5th webinar I'm giving for the Saudi German hospital group since the COVID pandemic has started. It's the 2nd that I'm giving for the Madinah people. And that's the reason why I thought this time I should propose a sort of a different title than the mainstream titles. And I chose this one, Unruptured Intracranial Aneurysms, Personalized Risk Assessment and Counseling. It's something that I have been interested in since a couple of years and have been doing personal research on it, and I will present some of that to you today. Now, seeing the number of attendants of this symposium, which is maybe in the range of 1,000 or so, including YouTube, I'm wondering of whether this is of interest to all of you, because of course the topic of unruptured intracranial aneurysms always comes up in countries with a relatively old population and in countries well equipped with MRI machines of high quality. This is certainly the case in Europe, Japan, North America, certainly also in Saudi Arabia. I'm not quite sure how many attendants will find this topic interesting, but I'll start my talk now. And this picture down here shows you what can happen to an intracranial aneurysm. Maybe you don't know that 3% of the adult European and North American and Japanese population have an intracranial aneurysm. 3% of the adult population. That's in Germany, it's 2.4 million or so. If you know that the incidence of aneurysm rupture, of aneurysmal subarachnoid hemorrhage, is between 6 and 8 per 100,000 per year, you immediately can calculate easily that a small minority will get sick of that during their lifetime. And of course, the question is how to predict who gets sick and how to predict who does not. This is what can happen to an aneurysm. After its formation, you see it here, it can stay the same, does not grow, does not rupture. It may, on the other hand, grow, even grow and compress cranial nerves or so. And of course, it may grow and rupture. And the problem, of course, and that's the topic of my talk, is how to predict which patient will take which course. And we have some data on this since a couple of years that I will show you. Now, as you can imagine, counseling patients with that problem has a lot to do with psychology. And before I go into the data, let me do a short introduction, a psychological introduction to how we counsel patients in medicine. And unfortunately, we don't have the opportunity to have votes, but I'll show you something. Now, imagine we have a scenario like this. A new pandemic called COVID-21, caused by SARS-CoV-2, is expected to kill 60 million people, let's say in the Middle East, North African region, or let's say in Europe. 60 million are expected to be killed by the new pandemic. Now, two strategies are discussed. Strategy one, strategy A, will save the lives of 20 million of the 60. Strategy B has 1/3 chance to save all 60 million and 2/3 risk that all will die. Now, unfortunately, we cannot have a vote on that, but I can tell you that this has been examined scientifically, and 72% of you will vote for option A, so saving the lives of 20 million. 72 will vote for strategy A. This has to do with counseling patients, as I will show you. Now, let's imagine a second scenario in the next picture like this. Same scenario, new pandemic expected to kill 60 million people in your part of the world. Two strategies are discussed. Now, imagine that you don't know the last slide. You have strategy A will result in the death of 40 million. Strategy B has 1/3 chance to save all 60 million and 2/3 risk that all will die. Now, if you immediately, of course, you all see that's exactly the same choice you have, only put in different words. And I can tell you 78% of you, not knowing the previous slide, will result for strategy B in this case, although it's the same choice that you have compared to the previous one, because that's human psychology. This is a loss frame. You're dealing with a possible loss of 40 million lives. That increases your willingness to take a higher risk to prevent them, favoring choice B. In the previous slide shown before, that's a gain frame, saving 20 millions. And that the gain frame is risk aversive, as we say. So you're not willing to take any risk because you have the 20 million safe. And you're preferring to save them instead of risking to or knowing to lose them, although it's exactly the same choice. Now, this is psychology, well known, has been awarded the Nobel Prize. It's called prospect theory in the 80s. So psychology is in the choices you offer, as you see in this example, but it's also in the question that you ask a patient. Let me show the next scenario. This is now more related to the aneurysm problem. Imagine that a condition is discovered that may cause a modified Rankin scale of 3 to 6, which is living dependently or being dead. And the estimated lifetime risk for this, for this event to happen is 5 to 10% for the rest of your life. Now, your choice, treatment A has 95% chance of cure and 5% risk of MRS 3 to 6 as a complication of the treatment. Treatment B is wait and see. Now, what's your choice? Unfortunately, again, we cannot have a vote, but I can tell you it will be 50-50 approximately. 50% will prefer 95% chance of being cured. The other 50% will say, well, 5% risk of something happening, which is all at the day of treatment, which is more or less the same as the risk for the rest of my life. I would prefer wait and see. So this is related to the aneurysm problem. This is a scenario, or let's say a choice or a question that I would expose to the patient, comparing risks of the condition related to the risk of treatment. Now, if you happen to, and as you know, I'm a neurologist, but if you happen to that the first patient you encounter, first physician you encounter with your problem is a neurosurgeon, at least in Germany and North Africa, many of them will tell you, you are carrying a ticking time bomb in your head. And of course, in this case, because you're emotionalizing the problem and increasing the risk, more than 90% will vote for treatment A because they will prefer the chance of cure over the risk of only 5%. So that's a psychology. It's in the options you offer and in the questions you ask. Psychology is also in pictures, as shown in the next. You can show a patient this picture. It's from a New England Journal paper in 2012, one of the big studies studying the natural cause of unruptured intracranial aneurysms from Japan. We will come to that back later. Now you can show the patient this aneurysm rupture risk. It's 1% per year over 3 years, so 3% at the end. But you can also show the same picture in this form because here it's exactly the same data, but the psychology is completely different. And of course, and the New England Journal has decided to display graphs as them only in both versions, in the psychologically risk aversive and the less risk aversive form. So that's the psychology in the aneurysm counseling mid-business or outpatient clinic. Now, as I mentioned, I don't know how big the problem is in your country. In Germany, it's quite a topic. You see here, year 2005, year 2017, it's a statistic showing how many inpatients were treated for unruptured intracranial aneurysms in Germany. It was 6,000 inpatients in 2005, and it was 14,000 in patients in 2017. Today is probably somewhere up here in 20,000 inpatients per year treated in Germany for intracranial aneurysms. We do not know from the German statistics how many were clipped and coiled. We don't know that, but they were treated as inpatients, and the number has more than doubled in 12 years. Now, what's the reason for that? The reason, of course, is that MRIs are more and more available, and the more MRIs you do for, let's say, headache, migraine, dizziness, or other problems, the more unruptured intracranial aneurysms you will discover. 3% of the adult population, as I mentioned. It's the problem is as double the size in women compared to men for whatever reason. I don't know. Of course, aneurysms are a little bit more frequent in women than in men, but certainly not double as frequent as in men. So maybe it's because women tend to get more MRIs for complaints who often do not deserve MRIs. So that's the statistic. And of course, it's a problem how to counsel these patients across all age groups. There are patients of 30 and patients of 70 years included, and the older they are, the older they are, they're more frequently involved in the statistics. So what about the location of the unruptured intracranial aneurysms? That's of some importance that I will refer to later. You don't have to go into the numbers here in detail, but maybe you keep in mind that 2/3 of all ruptured intracranial aneurysms found incidentally are less than 5 millimeter in size. So 2/3 are small being defined as less than 5 millimeters. Maybe you also should keep in mind that another 2/3 here are located in the middle cerebral and the internal carotid artery, excluding the offspring of the posterior communicating artery. So 2/3 located here. We'll come to that, back to that later. Only 5% are located in the vertebrobasilar circulation, unruptured aneurysms. That's of some importance. It's a condition of the higher age groups. When I went to medical school, we were taught that aneurysms are congenital malformations. And maybe some of you still believe that, but the opposite is true. It's an acquired malformation that's related to risk factors, as I will show later. That's a plot from the 1990s, where 5 autopsy studies in patients not having died of intracranial problems were looked at, and 5 intra-arterial angiography studies were screened of patients not having been investigated after intracranial bleedings or for vascular problems. It's tumor-related angiographies which were done at that time. So you see, the older the patients are, the higher the incidence or the prevalence of intracranial aneurysms. It develops, and it's very rare occasions you will find them in patients below the age of 20. Exceptions may be some syndromes such as Ehlers-Danlos syndrome, Marfan syndrome, but in the normal sporadic intracranial aneurysms, you don't have a syndrome, you have an acquired condition. And that's what we today believe, how it develops. Let's see this picture. You have seen that before. That's a very typical situation. You have here the anterior communicating on the right side, and you have the anterior communicating on the left. The A1 segment on the left and on the right, and the anterior communicating here. It's not a very rare condition that you have an asymmetry, and aneurysm patients often have such asymmetries, and then they start to develop aneurysms at the branching points of intracranial arteries. That's the typical location, as you all know, the berry aneurysms starting to develop at branching points of intracranial arteries. And why does this happen? That's what we today believe, and that's based on autopsy studies and histological studies of operated patients. It probably first starts with an endothelial damage, very much like the atherosclerotic vasculopathies. Endothelial damage then resulting in a breakdown of the basal lamina, the breakdown of the tunica media, so the smooth muscle cells disintegrate, you get inflammation, white blood cells. You don't get as much cholesterol as in atherosclerotic lesions, and you don't get that much proliferation. So the whole thing doesn't lead to a stenosis, but it leads to an excavation and a dilation of the vessel, and then keeps on growing. So it's a similar kind of vascular pathology as in atherosclerosis, with less proliferation, but with more dilation. And that's what happens. The aneurysm starts forming, then may grow. The growth of aneurysms, most probably, we know that from a number of studies, which I will not refer to, is probably not a continuous process. It's a process that has times of active growth and then long periods of silence. So it's a process, it's probably related to inflammation. The aneurysm is growing for some time, then remains stable again. And you see here, keeps on growing. And at some point in the life of the patient, it may also rupture. So that's what we today believe the aneurysm wall is looking like. It's a remodeled wall damaged by shear stress, by blood pressure, and by other endothelial toxic factors. And this has been proven. So referring to Professor Azar's talk, the same has been proven for intracranial aneurysms that have not ruptured. You see here, that's a case control study from the Netherlands. I will not go into the details, but they have studied huge databases, case control design, retrospective. And you see that smoking has an odds ratio of 3 to be associated with an intracranial aneurysm. You see that vigorous exercise 3 times a week has a preventive effect on the formation of intracranial unruptured aneurysms. You see that hypertension is as risk related as smoking. So you get odds ratio of 3 with hypertension. I can tell you that smoking plus hypertension gives you an odds ratio of 8. So it's more than additive. And if you add family history of subarachnoid hemorrhage, you also get over additive effects. The next thing that's interesting is that hypercholesterolemia, so low LDL or high LDL, sorry, also gives you a lower risk of developing intracranial aneurysms. That's the only finding that deviates from the standard risk factor pattern you see in atherosclerosis and in the aneurysm patients as well. So hypercholesterolemia is the only exception from the rule that the atherosclerotic risk factors are related to aneurysm formation and probably also to rupture. But of course, we do not know that from these data because this is only unruptured aneurysms. So that's what can happen to these aneurysms, as shown before. You see an aneurysm growing, rupturing. That's the bad case, worst case scenario. This is a second scenario that can happen. The aneurysm grows and then remains stable, and maybe 10 years later starts growing again but never ruptures. That's possible. Same other scenario shown here. Aneurysm ruptures, stays stable, and then ruptures without growth. That's probably a rare circumstance, but can happen. And the last thing here, last option, that's only rarely observed, but probably more frequent than we observe it, because you will not find such a unruptured aneurysms as shown here, because as soon as the aneurysm starts developing, it immediately ruptures. So it's a very short lifespan of this aneurysm, because short after formation it ruptures. And of course, it's unlikely that such a condition will be discovered in the phase before rupture as an incidental unruptured intracranial aneurysm. But that's probably more likely. And this also puts some restraints on preventing aneurysm rupture by recognizing incidental aneurysms, because some of them may form de novo in the future, even after successful treatment of an unruptured aneurysm. So how to predict that? And that's now the main topic of my talk, how to predict which patients belong to which category. And that's what I will show you in the next slides. Let's the only database we have, 6 prospective studies from all over the world. This is USA, Canada, Europe. This is Finland, this is Japan, this is again Japan, this is again Japan. So Japan is quite busy in that. And Japan has the largest numbers in patients, as you see here, the UCAS. I showed a picture from that before, more than 5,000 patients. But Japan has the shortest follow-up. So the longest follow-ups are from Finland and from the USA and from Europe. You have, in Finland, you have more than 20 years of follow-up. In Germany or US, Europe, you have about 10 years of follow-up in patient cohorts of this size you see here. So we have, let's say, taken together 10,000 patients who have been included in long-term prospective studies, all of them with unruptured intracranial aneurysms. And those are the number of events, meaning aneurysm ruptures, that have occurred during follow-up. And from these 6 prospective cohorts, the people, the research team of Gabriel Rinkel and colleagues in the Netherlands have extracted 6 prognostic features that allow individual personalized risk prediction, as I will show you in a moment. Now, the first factor is shown up here. And that's a bit amazing and astonishing. You see that it matters whether you're from Japan, Finland, or from another part of the world. The Japanese and the Finnish have a higher risk of aneurysm rupture. You know, this here is probability of rupture. This is years after discovery of the aneurysm. So Finnish and Japanese patients with unruptured aneurysms have a higher risk. That's very strange. I mean, you can speculate about genetic differences, but at least in Finnish people compared to the rest of Europe, that's not very likely. Maybe one explanation to this enigma is smoking, because Finland and Japan have a much higher, or have had in previous years, a much higher percentage of smokers than the other countries. It has come down, and since smoking is going down in Japan and Finland as well, the number of ruptured aneurysms is also going down. So maybe it has to do with smoking. Smoke is not included in this analysis because the 6 cohorts that I showed you have incomplete data on smoking. So smoking was not included in the analysis. So maybe this is smoking and not country of origin. Second factor is aneurysm location. You see here, the middle cerebral and the internal carotid artery have a much lesser risk, much lower risk of rupturing than the anterior communicating and the posterior communicating arteries. I showed you that in the beginnings. 2/3 of all unruptured aneurysms are located at these 2 more benign arteries. Hypertension is a risk factor. You get almost double as many in these cohorts, ruptures with hypertension than without. Patients who have had an earlier subarachnoid hemorrhage from a different aneurysm that has been treated also have a higher risk of rupture than those who have one incidentally discovered aneurysm, not ruptured. Patient age is of relevance. Patients above 70 have a clearly higher risk of aneurysm rupture than those below 70. And the most prominent and strongest predictor of rupture risk is aneurysm size. You see, the small ones have a small risk and the very large one have the highest risk. So these 6 factors now, taken together in a model, allow you to predict and to personalize your counseling of a patient with unruptured aneurysm together with his individual data. So let's assume for 1 minute myself having an anterior communicating aneurysm of 5 millimeter size, which I hopefully don't have. I haven't done an MRI myself, and I will never do it unless it's necessary. But let's assume I have an anterior communicating aneurysm of 5 millimeter size. What does the score extracted from the 6 cohort studies shown before does tell you now, or tell me for especially? I'm from Europe, so scored 0. I don't have hypertension, 0. I'm less than 70, 0. I have an aneurysm of 5 millimeter size, 0. I have not had earlier subarachnoid hemorrhages from other aneurysms, but I have an anterior communicating aneurysm, which is has a higher risk than internal or middle cerebral, as shown before. So this makes a score, a phases score, based on the previous cohorts of 4 in my individual case. What does that tell? It says down here is the phases score from 4. It tells me that I have a rupture risk. You see, phases score of 4 gives a rupture risk shown up here of 0.9% in 5 years. So I have a 0.9 mean risk of rupture over the next 5 years to come, with a 95% confidence interval between 0.3 and 2.0. So that's my individual personalized risk given the data that we have on my case. I mean, that's not nothing, but it's not certainly not a ticking time bomb, I would say. It's 0.9 in 5 years. That's something you can tell the patient instead of telling him you have a ticking time bomb which has to be operated or coiled immediately. 0.9. So this does not tell you, of course, anything about the risk comparison of spontaneous natural history versus treating you. This will be shown in the next 2 slides. That's unfortunately the most recent. It's from 2013. There has been no other since then. Meta-analysis of the risks involved in aneurysm clipping in unruptured cases. So patients being healthy before and then being clipped for an unruptured aneurysm. The mean surgical risk in these patients is 6.7. That's a huge number of patients, almost 10,000 studied here, and you see the risk is higher. That's some interesting sub-analyses on that. The surgical risk is higher in high-quality studies compared to low-quality studies. That's simply due to the fact that in the low-quality studies, the surgeon tells the scientist his complication rate. In the high-quality studies, it's an independent person, usually a neurologist, who measures the complication rate. It's also interesting that North America tends to have a higher risk in this meta-analysis than other parts of the world. Maybe it has to do, my personal speculation, that North America has a much higher number of neurosurgeons, so the number of procedures per neurosurgeon is lower, could be. There appears to be some improvement with time in clipping, which is a surprise because clipping has been around since many years, but maybe microsurgery has improved the numbers. So the more recent studies have a better risk than the previous ones. And of course, very simple, the older patients have higher risks than the younger patients. And of course, aneurysm clipping in the posterior intracranial circulation is much more risky than in the anterior circulation. And of course, the size of the aneurysm also influences surgical risk. The larger aneurysms carrying higher risk. Unfortunately, that's the same in the natural course. So the higher ones are the more risky ones to rupture, and the higher ones are the more difficult and risky ones to clip. So what about coiling? The figures are a little bit better, although you must keep in mind this is not a direct comparison between clipping and coiling, because the patients were selected for one or the other procedure before. It's not a randomized comparison. So coiling, nevertheless, and many of you will think the same, feel the same, has a lesser risk than clipping, but still, and there's no difference between good studies and bad studies. There's also, in this case, no difference between the continents, Asia, Europe, North America. So it's more homogeneous and a little bit less than clipping, although it's not a direct comparison, but still 4.8 mean risk is not low. I mean, and risk in this case is unfavorable outcome defined by MRS 3 to 6, as shown down here. So it's the same risk you have in terms of phases-based risk of rupture. So it's a severe, unfavorable outcome means a severely a relevant event, which makes you neurologically dependent after it. So 4.8 is not, it's not low, even with coiling. And if you once again consider my case with a 0.9% risk of rupture in an anterior communicating artery aneurysm for the next 5 years, comparing this with a 4.8 mean risk, which takes place on the same on the day of treatment. So it's a one-time risk on the day of treatment. It's something that you can at least think about. So this is one thing, phases score comparing with mean risk of treatment. This is the second thing. That's a paper that I was involved in, and the writing and the analyses leading to that paper. That's once again. This is an evident, let's say, expert-based thing. First, the phases score is a risk assessment comparing with mean risk of known, well-known, well-established treatments. Here in this case, we developed using the Delphi method. We asked 40 neurologists, neuroradiologists, and neurosurgeons. We gave them individual cases and asked them what they feel would the best decision on this individual patient would be. The patients differed, of course, in aneurysm size, aneurysm shape, age, sex, risk factors, life expectancy, things like that. It was a long-term Delphi decision analysis, and what came out of this was published in Stroke and Neurology, cited down here, and it gives you an expert-based individual decision. That's has not been prospectively tested. It's a treatment to no treatment comparison in experts. Now, once again, take my case. I'm over 60 years old. Give me 1 point for my anterior communicating aneurysms. This 1 point would score here. I have none of these risk factors shown here. I have no cranial nerve deficits or other events based on my aneurysm, embolic events or things like that. I have no malignant disease. The aneurysm that I have is 5 millimeter, gives me a second point here. The morphology, let's say, is smooth and round. The location is anterior communicating, that gives me 2 points here. There's no growth known of the aneurysm in my case, and my age, as shown here, is above 60, gives me 2 points on the treatment, red treatment risk scale. So this would end up in 4 points here in favor of treatment and 8 points here in favor of conservative management. So based on this UIATS, that's how we have termed it, unruptured intracranial aneurysm treatment score, this would be a clear choice, expert-based, interdisciplinary treatment choice, in my special case for conservative management. Now, what does conservative management mean? Of course, it means risk factor treatment, but it also means following the aneurysm size. And this is something, if you vote for wait and see and treat risk factors, you should follow the aneurysm size of the next years. Maybe the first scan should be redone after 1 year. The second, then, if the aneurysm does not grow, I usually recommend to have been done after 3 years. So if you have an aneurysm that starts growing, the risk assessment based on the phases score immediately jumps by a factor of 12. So patients where you have observed an aneurysm growth clearly are a different category of patients which should be treated with clipping or coiling depending on the individual case. So this is something very important, and by following the aneurysms you can pick out those who start growing, and treatment can start then before rupture, but most of them will not rupture. That's a statistic based on 4 cohorts, again from the Netherlands. You see that after 1 year, only maybe 2% of the patients show aneurysm growth based on MRA. After 2 years, it's already 10%, and after 20 years, almost 50% will show aneurysm growth, but it's a 20-year time frame which was observed here. So there is likelihood of 50% of aneurysm growth of the next 20 years, but also a 50% likelihood of staying stable and not growing over the next 20 years, making the aneurysms much more benign than the ones that are growing, factor of 12, as mentioned before. Now, how to predict aneurysm growth? There's a third score for that. I've shown you the phases score. I've shown you the UIATS score, and I've now show you the third score. It's the ELAPS score, published in 2017. It's based on very similar criteria as the phases score, but in this case, you predict aneurysm growth. Again, it's an earlier subarachnoid hemorrhage from a different aneurysm that gives you 0 points or 1 point, depending on what kind of case you are. In my case, it would be no, meaning 1 point. The anterior communicating and internal carotid artery aneurysms have a lesser tendency to grow than middle cerebral or posterior communicating. Age also makes a difference. Aneurysm growth is more likely in the older people. Again, strange finding, Japanese and Finnish people have a higher likelihood of aneurysm growth, but as mentioned before, that's probably due to a much higher prevalence of smokers. The aneurysm size makes a difference. If you have a 6 millimeter aneurysm, as in my case, or 5 millimeter, sorry, it gives you 10 points. And the shape of the aneurysm also makes a difference. So based on this score, you can predict the likelihood of aneurysm growth over the next 5 years. It's something, why doesn't it move? Yes, this is it. For instance, my case would be 10 ELAPS score points, meaning that I have a 20% risk of aneurysm growth in the next 5 years. And if that occurs, if this 20% chance would come true, my risk of rupture immediately jumps by a factor of 12. So it may be worthwhile checking the size of the aneurysms over the next years before treating them right away, at least in low risk cases like myself, 0.9 over 5 years risk of rupture. So this is now almost over. My time's almost over. I have shown you these 3 scores that may help you in personalized counseling of patients who happen to have an incidental unruptured intracranial aneurysm. And if you vote for wait and see, then you should follow aneurysm size. And the next slide is what you should not do. Once again, it doesn't move for some reason. Yes, what you should counsel them for is you should make risk assessments based on rational principles, such as the phases score. Don't tell them they have a ticking time bomb. Calculate their risk and tell them their risk. And also tell them that the short-term risk of rupture is small. Advise smoking cessation. That's not included in the scores. Nobody knows what the effect of smoking cessation is, but I presume it's high. Treat arterial hypertension as in all other vascular conditions. Refer the patients to a dedicated cerebrovascular center where they get different interdisciplinary advice from neurologists, neurosurgeons, neuroradiologists. Don't refer them to just one person who only has one kind of treatment and therefore is biased towards this kind of treatment. And advise follow-up imaging if you and the patient decide to wait and see. What you should not do is summarized in this slide. Avoid emotionalizing terms such as the ticking time bomb. Avoid risk assessment of an aneurysm based on only a single parameter such as size or location. Always take a whole picture. Do not impose restrictions on physical activities, as shown before. It's probably more effective than it does do any harm. And there are also studies in that. There's no reason to advise screening of family members of patients with incidental unruptured aneurysms, unless you have these rare cases of true familial aneurysm disease, FIA, where the risk also is higher. In these families, screening may make sense, but in the usual, let's say, spontaneous UIA patient, it does not make sense to screen his family. So that's what I wanted to tell you, and I'm looking forward to the discussion and the panel round later. Thank you very much for listening.
Many thanks to you, Professor Dr. Helmut. Really, it was fruitful. And for me personally, I have learned a lot through that presentation, because that topic is underrated regarding our clinical practice in neurology. And it is challenging for patients and relatives when they discovered that they have aneurysm accidentally, and what should they do? They are in panic to do what? So I think it is fruitful to highlight in such an approach. And for our audience, if anyone wants to ask a question, he can put it in question and answer taskbar. And now we are moving to Dr. Ahmed Kohil, the neurologist of Saudi German Hospital Madinah, coordinator of stroke program, fellow of European Board of Neurology. He will take us through interesting various case scenarios in order to be more applicable and touchable to our audience. Dr. Ahmed, you can start. Could you unmute the voice, Dr. Ahmed Kohil? Dr. Ahmed, could you unmute yourself?
Okay, you hear me?
Yes, I hear you well. You can start, Dr. Ahmed.
Greetings all. First, I would like to extend my sincere thanks and appreciation to all those involved and participants in the success of this wonderful work. Thanks to all speakers from different parts in the world. Thanks to Saudi German Hospital for giving us the chance to establish this great work. Also, it is of my great honor to be in this session with two great professors, Professor Dr. Azza and Professor Dr. Helmut, and I would like to thank them about their valuable lectures. Let me start my presentation. Stroke cases, various clinical scenarios. Case number 1, a female patient, 30-year-old, known case of migraine with frequent attacks, but not on prophylactic medications. On 19th of September 2016, she was following up with an obstetrician for primary infertility for 1 year. She had irregular cycles, missed period, and normal level of LH, FSH, and thyroid stimulating hormone. Transvaginal sonography showed normal ovaries with multiple premature follicles. She was started on metformin and clomiphene sulfate as a case of polycystic ovarian disease. On follow-up, transvaginal sonography showed no dominant follicles. So FSH injection epigonal started. After multiple visits, there was no improvement in her condition. On 4th of February 2017, she was started on norelcesterone, Primolut-N. 6 weeks after that, on 15 March 2017, she presented in emergency department with abdominal pain, nausea, acute increase in body weight, and fatigue. Hemoglobin was 17, and hematocrit was 47. Ultrasonography showed ovarian enlargement with multiple follicles, 33 millimeter uterine thickness, and marked ascites, picture suggestive of ovarian hyperstimulation syndrome. She was admitted for intravenous fluid therapy and abdominal drainage of ascites. Additionally, elastic stocking and low molecular weight heparin prophylactic dose were initiated. She was discharged with a normal hematocrit on thromboembolic stockings and prophylactic dose of low molecular weight heparin. 1 week later, she presented to emergency department with acute left-sided weakness 36 hours ago. Upper limb is more affected than lower limb, hypotonia, deviation of angle of the mouth to the right side, and dysarthria. There were no seizures, trauma, disturbed conscious level, or fever. At that time, her neurological examination revealed fully conscious state, dysarthria, left side weakness, upper limb power grade 3, more than lower limb, which was power grade 4, distal more than proximal, with hypotonia, hyporeflexia, and the plantar reflex was extensor in the left side. NIHS score was 6. At that time, MRI brain, MRV, and MRA intracranial vessels were done, which showed right basal ganglion and peri-insular area of restricted diffusion, together with occlusion of the right MCA after the M1 segment, while MRV was unremarkable. The patient was out of window of either thrombolytic therapy or mechanical thrombectomy. Moreover, pregnancy test was positive. Hemoglobin was 18, hematocrit was 48, plus 3 proteins, plus 2 blood in urine. Hair collagen profile and the thrombophilia screen were unremarkable. This is an MRI diffusion weighted image showed. This is recent right basal ganglionic infarction. This is an MRA showed occlusion of after M1 segment of right middle cerebral artery. MRV was unremarkable. She was admitted as a case of acute ischemic stroke as a complication of ovarian hyperstimulation syndrome and was treated accordingly. And she was commenced on low molecular weight heparin for the remainder of her pregnancy. The patient improved neurologically through the rest of her pregnancy with normal fetal growth parameters and the structural scans for fetal anomalies. She eventually delivered a healthy, normally grown baby boy at 39 weeks gestation by elective cesarean delivery. At the time of delivery, she had a power grade 5/5 of her left lower limb and a grade 4/5 power in her left upper limb. This is the first case. Case number 2. A 15-year-old female with a history of sickle cell disease, hemoglobin SS genotype since birth, with recurrent sickle cell crises and exchange transfusion. The patient was presented to emergency department with a 3-day history of severe headache, impaired concentration, and pain in her legs and arms. The patient experienced worsening of headache and concentration over that 3 days despite painkillers, paracetamol 1 gram 3 times daily since symptoms started, and then developed recurrent attacks of generalized convulsions, followed by disturbed conscious level state and left-sided weakness 2 hours before presentation to emergency department. Glasgow Coma scale at that time was 10/15. Vital signs: heart rate 112 beats per minute, respiratory rate 21 breaths per minute, temperature 37.3, blood pressure 145/90, oxygen saturation was 95% in room air. There was zero discoloration of sclera in both eyes. Underweight, body mass index was 17, myalgia, different sides of her body, palpable enlarged spleen. Other general examination was unremarkable. Neurological examination revealed dysphagia, conjugate eye deviation to the right side, left-sided weakness, lower limb power grade 3, and upper limb power grade 4. Weakness was distal more than proximal, left-sided hypotonia, lower limb more than upper limb. Reflexes were risky in the left side, left extensor plantar response. Neurological examination of the right side was unremarkable. And other neurological tests, including sensory examination and tests of coordination, could not be assessed accurately at time of examination due to impairment of conscious level. The patient developed another witnessed generalized tonic-clonic seizures while being transferred to a brain imaging room. Status epilepticus protocol was started and 0.3 mg per kg midazolam given IV, followed by loading phenytoin 20 mg per kg, and the seizure was aborted, and the patient had CT scan without contrast, which revealed bilateral frontal, cortical, and subcortical hypodense ischemic lesions, mainly involving anterior and paraphalangeal region, in addition to minimal hyperdense smearing of subarachnoid space. in right anterior frontal, parasagittal, and bilateral high frontal cortical sulci, which appear here in the CT brain. Significant laboratory results: LDH 437, creatinine was high 1.9, total bilirubin 4, direct bilirubin 0.9, and PCR for COVID-19 was negative. INR 1.3, hemoglobin 8.9, reticulocytic count was 7.2, hemoglobin S was 39% of total hemoglobin. CT angiography was recommended and discussed with parent benefit risk ratio, but they refused at time of admission, or also refused doing digital subtraction angiography due to possible risk of renal failure. The patient was then admitted in intensive care unit, and hematologists recommended for exchange transfusion as she was in crisis, and repeated till hemoglobin S become less than 30% of total hemoglobin. The patient was given nimodipine 60 mg every 4 hours through NGT with monitoring of blood pressure plus phenytoin 100 mg intravenous twice daily, IV fluids in addition to physiotherapy, and intermittent pneumatic compression for venous thromboembolism prophylaxis. The patient regained fully conscious after 1 day, mild dysarthria, left side weakness, the same grade at time of admission, sensory examination intact, no seizure recurrence. By the second day, kidney function tests improved, and the serum creatinine become 1.2, and parent accepted to do CT angio, which revealed sacral aneurysm here as junction between anterior communicating artery and A1 segment A1 segment of anterior communicating artery and A1 segment of anterior cerebral artery. Here, junction of anterior communicating and A1 segment of anterior cerebral artery. Also marked attenuation of right internal carotid artery and both anterior cerebral arteries, mainly right one, denoting vasospasm. Parents refused digital subtraction angiography after discussion between parents, hematologist, neurovascular interventionalist, and neurologist. The patient showed significant improvement in the next days regarding hemodynamics, seizure control, left-sided weakness, which become full power in left upper limb and grade 4 in left lower limb. Speech become intact regarding articulation, comprehension, and repetition. Sickle cell crisis subsided after 4 sessions of exchange transfusion, and hemoglobin S become less than 30% of total hemoglobin. Jaundice subsided, valor improved, hemoglobin become 10.4. CT brain without contrast follow-up revealed significant regressive course regarding the subarachnoid hemorrhage and also the vasospasm, totally resolved from the left frontal, and the remaining very small area of vasospasm in the right frontal area. The patient was then discharged home after 10 days and appointed for follow-up at neurology and hematology outpatient clinic with a plan for rehabilitation. This is the second case. Case number 3. Female patient, 77-year-old, past history of hypertension, diabetes mellitus, ischemic heart disease. The patient was presented to emergency department complaining of sudden onset and stationary course of right-sided weakness, impaired speech, articulation, comprehension, and repetition, 2 hours and 30 minutes before presenting to emergency department. The patient Glasgow scale was 10/15. Blood pressure was 150/95 millimeter mercury. Heart rate was 98 beats per minute. Random blood sugar was 230 mg per deciliter. Oxygen saturation was 96% on room air. At the time, cold stroke in the hospital was activated within 4 minutes of the patient arrival to emergency department. General examination of the body system other than central nervous system was unremarkable. Neurological examination revealed global aphasia, right upper motor neuron facial paralysis, conjugate deviation of both eyes to the left side, right gaze palsy, right side hemiparesis, upper limb more than lower limb, distal more than proximal, power grade in the upper limb was 1 and in the lower limb was 3. Right-sided hypotonia, right-sided hyperreflexia. Right extensor plantar response. Neurological examination to the left side was unremarkable. Sensory examination and tests for coordination could not be assessed at that time due to impaired conscious level. NIH's scale was 18. At that time, two wide bore IV access were placed. Nasal oxygen 3 liters per minute was placed after drop of oxygen saturation below 94%. The patient was urgently sent to CT room, and the door to CT time was 15 minutes. CT brain without contrast, as shown here, showed early signs of ischemia in CT, loss of gray-white matter differentiation, obscuration of lentiform, and the loss of insular ribbon. Aspect score was 7, and the door to CT interpretation was 25 minutes. Laboratory investigation, INR 1.1, other routine labs were unremarkable. The patient was revised regarding inclusion and exclusion criteria to receive IV RTPA, and she met it. Discussion was done with the patient first degree relatives about benefit risk ratio of receiving IV RTPA, and written consent was obtained, and RTPA was rapidly prepared after calculation of total dose 0.9 mg per kg. Bolus dose 10% of the total dose was given, and the rest of the dose given over 1 hour. Door to needle time was 38 minutes, and the onset to treatment time was 3 hours and 8 minutes. The patient had CT angiography while she is on IV RTPA infusion, which showed left carotid bulb calcified atheromatous plaques with luminal stenosis 55% and distal extension of mural thrombus, internal carotid artery, with distal progressive narrowing up to total occlusion of distal bifurcation and middle cerebral artery. The patient was candidate for mechanical thrombectomy, and the door to groin puncture was 70 minutes. And IV RTPA was still infused till time of groin puncture and then hold it. The MCA clot was removed using stent retriever device. Successful recanalization of both left internal carotid artery and left middle cerebral artery was achieved as shown in the following image. This is CT cerebral angio, showed stenosis left internal carotid artery with near total occlusion at the site of bifurcation and left middle cerebral artery. This is after mechanical thrombectomy with successful recanalization of both left internal carotid artery and left middle cerebral artery. After successful recanalization, the patient was re-evaluated and became fully conscious, mild dysarthria, mild right upper motor neuron facial paralysis. The right hemiparesis improved from severe weakness to mild weakness in right upper limb, power grade 4, and right lower limb, power grade 5. NIH's score was 4. The patient was then transferred to stroke intensive care unit to complete the plan of management with tight control of vital signs and careful monitoring of both general and neurological condition. The patient completed her stroke workup, which was unremarkable except hyperlipidemia. LDL was 221. Also, early physiotherapy was started, and CT brain without contrast follow-up was done after 24 hours, which revealed acute left basal ganglia infarction. Here. Acute left basal ganglionic infarction with no hemorrhagic transformation. Consequently, anti-ischemic preventive measures were started. After improvement of the patient condition, she was discharged to stroke ward and sent to home after 5 days of hospital admission. And her modified Rankin scale at that time, which post-stroke disability was 1. The patient was appointed to follow up in a stroke preventive clinic and rehabilitation program. Thank you.
Thank you so much, Dr. Ahmed Kuhail, for that interesting cases, which is real cases from Saudi German hospital, Medina. And I think it was various and cover rare cases and standard pathway for stroke patients regarding possible acute treatments. And now we will go for question and answers. We have a question to Professor Dr. Helmut. The studies you mentioned it in your presentation, having a score based on Finnish and European and North American and Japanese. What will you use for criteria for patient with unruptured intracranial aneurysm if that patient from Africa or Middle East? Will you apply that criteria to the patient or use just benefit risk ratio?
But this has nothing to do with the cases you showed, huh?
Yes, Dr. Helmut?
Yes. Your question was, I didn't get the entire question. So your question,
you mentioned in your presentation that you use criteria for Finnish, North American, European. What if the patient is African or Middle East? Will you apply such criteria to him or just benefit risk ratio?
Yeah, I would apply the same criteria to him or her as for the North American or European population, because I do not assume that the ethnic differences that apparently are in there are really related to ethnic differences. I think it's more differences to lifestyle, smoking, risk factor treatment. So I would apply the same criteria for patients from other parts of the world.
The same criteria.
Yeah.
Thank you. Okay, we have a question for Dr. Azza Abdel Nasser. Patient who have hypercoagulable state with cerebral venous sinus thrombosis, and the patient has no cardiac problem. What would you prefer, warfarin or new oral anticoagulant if the patient and relative feeling of commitment to multiple INR test or unsteady state of warfarin? Will you recommend new oral anticoagulant over warfarin or not?
Yes, okay. I think the oral anticoagulant, direct oral anticoagulant is preferred than the warfarin because it is effective and it has no monitoring follow-up, so it can be all the time. It is can be consistent, no changes in the blood serum, in the blood level of the anticoagulant like warfarin. Warfarin has a great problems in stabilization of the serum level and needs all the time monitoring for the INR. So I think the direct oral anticoagulant can be preferred.
Okay, thank you so much. We have a question for Dr. Ahmed Kuhail regarding the case of sickle cell disease. You mentioned that the patient have ruptured saccular aneurysm, and at the same time, the patient has chronic occlusion of right internal carotid artery, and she has cerebral vasospasm. And you mentioned that relatives and the family refuse intervention at that time. What will you use in that dilemma if the patient have severe cerebral vasospasm or underlying ischemia, and you have ruptured saccular aneurysm, you didn't intervene with it? What will you use regarding anti-ischemic measure, especially you will not able to use triple H therapy in unsecured aneurysm? Unmute the voice, please, Dr. Ahmed Kuhail.
Okay. At the time of admission, the patient was treated from the hematology point of view, treated by repeated regarding hematologist, and after that we'll follow up with hematology clinic I think they always prescribe the patient not anti-ischemic but hydroxyurea, like Dr. Azza said in her presentation. Yes. So, and regarding the aneurysm, we'll just follow up, but the patient relative refused totally to do digital subtraction angiography at the time of admission. So we will follow up the patient. The patient will come to follow up.
Dr. Helmut, do you want to add anything regarding that question?
No, I mean, this is really a very terrible case. I mean, it's very unusual to have an aneurysm at the age of 15, I must say.
Yes.
Yes.
I don't have experience with sickle cell disease because, as you can imagine, patients are not very are rare here in Europe. Is this something that you have encountered in other cases as well? So aneurysms in a 15-year-old patient with sickle cell disease. I never heard of that. Is it related?
Yes.
Only few literatures mention that there is very rare cases presented with intracranial aneurysm accidentally discovered in sickle cell patients.
Okay.
Dr. Azza, we have a question also for you. Regarding the patients who have antiphospholipid antibody, and only in the history she has anticardiolipin positive and the previous history of abortion, but it was in the first trimester, not in second trimester. In that patient, will we use the anticoagulant or antiplatelet?
I think anticoagulant is best for even the patient who have isolated antiphospholipid antibody but not fulfill the whole criteria. We prefer for him the antiplatelet therapy. But the patient who have fulfill the whole criteria of the antiphospholipid syndrome, he must be treated with warfarin. The patient who have the criteria for the antiphospholipid syndrome, who meet some of the criteria of the antiphospholipid syndrome, it was reasonable to anticoagulate him with warfarin.
So if that patient have another pregnancy, she will use anticoagulant like Clexane, or she will stay on aspirin only?
I think during pregnancy, Clexane is best preferred in pregnancy because it's safe. I must stop antiplatelet like aspirin and change into Clexane.
Okay, thank you, Dr. We have a question for Professor Dr. Helmut regarding MCA aneurysm, not ruptured, and its size is less than 1 centimeter. According to guideline, no intervention with it. But if that patient is old age and uncontrolled blood pressure and poor lifestyle, at that time, will you recommend intervention or just follow up, especially if the patient is resistant to lifestyle modification and control of hypertension? Will you change your decision in that patient? Could you unmute the voice, Professor Helmut?
Sorry, forgotten. The question would be high age. What does that mean? But if it's, let's say, above 70, above 60 or so, I would probably vote for wait and see, conservative management. I mean, regarding guidelines, that's very difficult because so far there's no randomized control study about this topic, this question, what to do with these patients. In order to really have a good guideline, you should have to rely on a randomized controlled trial giving you the high evidence level 1 recommendation, but this doesn't exist. So it's always something which of course needs personal risk assessment and psychology of the patient. I mean, there are some low risk patients who cannot live with the concept of having an intracranial aneurysm, and they, of course, this can become this may be a treatment indication in some of them, because if they can't live with it, it may also be an indication to operate or to coil the aneurysm. But in this case that you mentioned, old, bad lifestyle, 1 centimeter middle cerebral, not willing to, not demanding treatment, I would certainly vote for wait and see.
I have my question. We have go with you through the guidelines, through the study. Could we change the decision if we find a patient with unruptured intracranial aneurysm and he is a sportsman, like a boxer, or practicing heavy exercise, aggressive exercise, like lifting heavy objects? Will we wait or we go through it?
Yeah, but that's psychology then. There's no, there's no really good data on whether weightlifting really causes aneurysm ruptures. I mean, it's something that we intuitively believe, but I have never seen such a case. And I mean, it's certainly something that depends on the patient's psychology. If he cannot live with the fear of aneurysm rupture, then of course it's something where I would recommend treatment. But nobody has shown that weightlifting, and what should be the concept? I mean, that weightlifting causes aneurysm rupture.
Okay, so could we use consider significant psychology of the patient or even the occupation of the patient in changing the decision?
So, I mean, patients are of a different kind. I don't know whether I understood your question correctly, but there are patients who say, I cannot live with an unruptured aneurysm, take it out or occlude it. Then this is something that you have to consider and probably recommend treatment. There are others that say, if you cannot tell me whether this aneurysm will ever rupture in my life, I will not have anybody open the skull or put a catheter in my brain to occlude this thing, which is more likely to not rupture during my life than to rupture. I mean, this is individual patient psychology, which has to be considered, of course. It's a reason to wait and see or to intervene.
Thank you, Professor Dr. Helmut. We have a question to Dr. Ahmed Kuhail. Could you unmute your voice? Dr. Ahmed Kuhail. We have a question from one of the audience about your case of sickle cell disease. The patient age 15-year-old, and you mentioned that relative refuse to do digital subtraction angiography or even intervention. Regarding the medical, legal, and the ethical issue, can that patient share in the decision or left it for her family for such a big decision?
A very good question, because we're thinking about this issue when we're dealing with such a case, but we are dealing here with the cultures here. They consider the patient 15 as a child here. So, and also she is a child, 15 years, so she cannot take decision about anything. So the relative, regarding our culture or even all Arab culture like this. So the decision with the relative, her father and her brothers at that time.
But
so the patient
at that age, she could able to take decision or waiting for another age, because it's different from country to country.
It's different from country to country. But here I'm talking about the culture here. The culture here, the patient is too young to take such a big decision like this.
Okay.
And the relative, please, Prof. Helmut.
I just wanted to add, of course, it depends on culture and on country. In Germany, we could, in principle, call a judge and ask him for the decision. But of course, to do that would mean you have a total conflict with the family.
Yes.
and you would split child from family and things like that. So we would probably not do it, but legally we would be allowed to call a judge, and probably the judge would decide against the parents in this case. But
Yes.
we would also be very reluctant to do that. It's reserved to single, very strange cases of children with leukemia, where the parents have strange ideas of paramedic treatment and things like that. There's cases like that where judges decide for bone marrow transplantation and things like that, but not in a case like this, I would think.
Okay.
We have last question for Professor Dr. Azza. If you have a patient with silent infarction and no past history of any stroke symptoms, will you use for such a patient antiplatelets or just modification of risk factors?
First of all, I will modify all the risk factors and search for his vascular risk factors, the hypertension, diabetes, lipid profile, lifestyle, especially smoking, and will ask him to change his lifestyle, and I will ask him to follow up his risk factors and good control for the different vascular risk factors. But in this case, if I found vascular silent infarction, I must give single antiplatelet. I will give aspirin, even in a low dose, 75 milligrams. I must give.
Okay,
with the good control of different vascular risk factors.
Exactly, that's clear, Dr. Azza. We have the last question for Professor Helmut. Does the pathology of or type of aneurysm, secular from fusiform aneurysm, differ in the plan of counseling for patients or not?
Good question. Good question. I should have mentioned that. All what I said referred to secular aneurysms. Then the fusiform aneurysms are a completely different thing, and of course much more difficult to treat. So what I said is secular aneurysms. Fusiform is a different topic. But of course, most of them are risk factor related. Some of them are infectious in origin. So, and of course, you can in these cases, in most cases, you can only treat the infection or the risk factor profile.
So that approach is conclusive to secular aneurysm,
yes,
not fusiform aneurysm.
Yes.
But no studies available about similar to such secular aneurysm counseling about fusiform?
No similar studies to fusiform aneurysms. Much rarer, of course, and no.
But it is more dangerous, in your opinion?
Yes, of course. You cannot do clipping. In most cases, you will not be able to do clipping, and of course, you cannot do coiling. I mean, you could do stenting, but this is single case experience. I mean, this is nothing that has been put in studies of relevant numbers of patients.
So it is area for future study.
Yes.
At the end of our second day of International Saudi German Hospital Stroke Symposium, I'd like to thank our dear guest speakers, Professor Dr. Helmut, Professor Dr. Azza Abdel Nasser, Dr. Ahmed Kuhail, for such valuable, precious presentations. We got a lot of updated information about various topics, and many thanks to all our audience who stayed with us till the end of our day. And we want to remember you about tomorrow, the third day of Saudi German Hospital International Stroke Symposium. We will have Professor Dr. Ashfaq Shuaib, Professor Dr. Ahmed Al-Basyuni, and Professor Dr. Islam Al-Souqi, and me will give a presentation for non-neurologists. Hope to stay tuned and get benefit from our presentations, and hope for you good night and good luck. Thank you so much.
Thank you, Dr. Muhammad, for your magnificent moderating this session, and big thanks to my respective doctors and Professor Dr. Helmond, Professor Azza and Dr. أحمد. وفي نهاية هذا اللقاء لا يسعني إلا أن أشكركم أنتم اللي حاضرين معنا إن شاء الله. Thank you a lot for your attending. سبحانك الله وبحمدك استغفرك وأتوب إليك. نراكم غدا إن شاء الله على خير. السلام عليكم.
Thank you for goodbye.
Thank you. Thank you very much.
Cheers.
Thank you.
Bye-bye.
Thank you.
Welcome.